Welcome to another session of the e-classes for you. Today, we would be discussing long-term outcome and follow-up of fallow. This is the talking. I should explain to you why is it that this particular topic, after all, we are speaking about following up one particular post-surgical entity. What is the importance of this? Surgical repair of tetralogy was an important landmark in the history of pediatric cardiology and cardiac surgery. It was Lillet and his group who did it in 1954. The important thing about tetralogy is the misnomer word that we use, intracardiac repair, total repair. It is true that complete repair of tetralogy alters the life expectancy dramatically, but it's not curative. And the patients are abnormal, their hearts are abnormal, anatomically, physiologically, and electrophysiologically. And long-term survival of repaired tetralogy is not equal to that of general population. And the number of patients with repaired tetralogy is increasing so much that there is a major post-op population with a very considerable cardiac and non-cardiac disease burden. And this number is growing rapidly. And this group has an annual mortality rate which increases by 0.1% per decade. Therefore, we have a new disease, let's say a new epidemic, repaired tetralogy. This is a disease that needs understanding so that you can follow up. Why is it that this disease is so distinctive? There are a number of structural and functional abnormalities which are encountered in repaired TET. The structural abnormalities, some of them are inherent to tetralogy repair. For instance, the surgeon has partially or completely removed the pulmonary valve tissue. There is a scar on the RV infundibulum quite often. RV or infundibular muscle fibers have been resected. A right atriotomy scar is there for sure. There is a VSD patch. These are all integral components of TET repair. But some lesions may be residual or recurrent, like RVOT obstruction, stenosis of the pulmonary arteries anywhere, and a ventricular septal defect, part of it may remain. There may be an atrial septal defect which is left behind by the surgeon intentionally initially or unintentionally. And some lesions manifest as the child grows older, like tricuspid valve abnormalities, an aneurysm of the RV outflow tract from an infundibular scar or patch, fibrosis of the right ventricle, it has been ischemic and hypertrophy, associated anomalies like a dilated aorta, the significance of which now we are understanding a lot more than what we did, say, maybe 20 years ago. Associated congenital cardiovascular anomalies, associated genetic and non-cardiac anomalies, notably 22q11 syndrome and 22q11 deletion and its effects. Functional abnormalities like right ventricular volume overload from pulmonary regurgitation, TR, any residual left to right shunt, pressure overload if some RVOT obstruction has been left behind, or there may be pulmonary vascular disease or pulmonary arterial stenosis. RV systolic or diastolic dysfunction, LV dysfunction, the problems from right bundle branch block, arrhythmias, both supraventricular and ventricular, and comorbidities in the other system. So you have a Pandora's box that you're opening once you have repaired a tetralogy. Of this, the most important one is pulmonary regurgitation. It is a key hemodynamic lesion which will eventually lead to progressive right ventricular dilatation and biventricular dysfunction. It's peculiar that it tends to increase with time, and as it increases, it places a volume load on the right ventricle, which gets exacerbated by any RV outflow tract or distal pulmonary artery obstruction. And related to pulmonary regurgitation, one of our main concerns is when should we replace the pulmonary valve? Should we replace it? And if you replace the pulmonary valve, how do you follow up the patient who has had the replacement of the pulmonary valve? The determinants of pulmonary regurgitation are, we would explain this with the Torricelli equation, the next slide too, the regurgitant office area, the compliance of the right ventricle, the pressure difference in diastole between the pulmonary artery and the right ventricle, the capacitance of the pulmonary arteries, and the duration of diastole, in other words, the heart rate. So this is derived from the Torricelli principle, which relates the PR volume to the regurgitant office area, the diastolic time, the pressure gradient between the MPA and the RV, and some constants. So as we explained in the previous slide, the three important things are the annulus area, the diastolic pressure in the RV and in the pulmonary artery, which is decided in turn by the pulmonary arterial capacitance and the RV diastolic function. So the PR depends on the gradient between PA and RV in diastole, which would be very little. Pulmonary valve office size is very important. And the diastolic pressure in the PA would depend on the vascular recoil after systole and also the transmitted pressure from the left atrium. And the RV diastolic pressure would depend on the RV compliance. This helps us in understanding why is it that pulmonary regurgitation is progressive after TET repair. You know that there is pulmonary regurgitation always practically after tetology repair, always if there is a transannular patch. RV dilatation is the consequence of this. With passage of time, the RV compliance increases. As the RV compliance increases, remember the pulmonary regurgitation is bound to increase as the pressure gradient in diastole between the PA and the RV is increasing. And as PR increases in the pulmonary artery, the pulse volume increases and the PA pulse pressure increases, and this leads to PA dilatation and increased capacitance. Increased PA capacitance also leads to pulmonary regurgitation. That is why pulmonary regurgitation is triggering a chain of events which eventually leads to a situation of PR begetting PR. And how does the right ventricle behave in response to the PR and also the multiple insults that has happened in relation to a tetology repair? This is very similar to what happens to left ventricle in aortic regurgitation, but there are important differences as well, because these are differences which are brought on by the differences in chamber geometry, the myofiber architecture, the way the chamber contracts, the coronary artery anatomy, the flow dynamics, the way the conduction system is disposed, and how much the LV size and function are altered by a dilating RV. You could say that RV function impacts LV function. In the normal situation, the reverse is much more pronounced, as much of the RV pressure rise is contributed by the LV contraction. In tetology repair, you have to relieve the RVOT obstruction. How would the surgeon do that? He has to incise the infundibular free wall. He has to resect the obstructive muscle bundles. He has to disrupt the pulmonary valve with partial or complete excision. He has to place an outflow patch which may extend across the plane of the pulmonary valve into the MPA and quite often into the LPA. One or more of these has happened to your patient. And in some patients, there is a conduit between the RV and the PA. VSD is closed with a patch. The patch can catch the tricuspid valve and cause tricuspid regurgitation. It can cause complete heart block. It's a different matter, which fortunately happens only today in a small percentage. So there is pulmonary regurgitation, there is dyskinesia or akinesia of the RVOT. There could be an outflow patch aneurysm. there is an RV free wall fibrosis and conduction delay. In this MR specimen, in this MR image, see the right atrium, the right ventricle here, and an aneurysm in the RV outflow. We have today a lot of insights from cardiac MR into the function of the right ventricle. And we drew the analogy between the LV function in chronic aortic regurgitation and the RV function in pulmonary regurgitation. They are similar to the extent that once the compensatory mechanisms fail, the mass to volume ratio decreases. There's more volume and less mass. So the end systolic volume increases and the ejection fraction decreases. If you look at this curve, this is ejection fraction on the y-axis and end systolic volume, both for the right ventricle, on the x-axis. And what do you find? As the end systolic volume increases, the RV ejection fraction is steadily decreasing. And the factors that affect RV mechanics in repair pathology of fallow, directly related to surgery, if you want to enumerate, how big is the outflow patch? How much fibrosis of the right ventricle is there? How much impaired is the RV diastolic function? What is the level of left ventricular function? How much is the conduction time? That's the AV conduction time and the interventricular conduction time. The dyssynchrony of the RV contraction. And what was the age at which the TET repair was done? This is a busy slide, but this is only to show you that tetology repair results in right bundle branch block, it results in pulmonary regurgitation, and the pulmonary regurgitation leads to RV volume overload, RV dilatation, all the physiological changes that we said and leading to RV dysfunction. At the same time, the infundibuloplasty leads to an RVOT aneurysm, which also causes RV dysfunction. This dysfunctioning RV affects the functional status, causing sustained ventricular tachycardia and maybe sudden death. And the RV dysfunction also leads to ventricular dyssynchrony. There are other factors influencing this, and these are parts of tetology repair. And we speak of the ventricle-ventricle interaction in normal physiology. In TET repair also, there is an RV-LV interaction which eventually adversely affects the patient's functioning. You know that both the ventricles function in series, and in the absence of shunts, the net outputs are similar. You might have heard the word Bernheim effect, where the French physiologist Bernheim described the interdependence between the LV and RV function, and we use the word Bernheim effect for the impact of mitral regurgitation induced LV volume overload on the function of the RV because the septum is displaced into the RV. Now I'm referring to the left ventricular size and the septal displacement into the right ventricle. What is the clinical consequence? The JVP gets raised. That is the Bernheim effect. In tricuspid regurgitation or pulmonary regurgitation and RV volume overload, the septum gets shifted into the left ventricle. Now it's a reverse Bernheim effect, and this adversely influences the LV function. The interaction between the ventricles after tetology repair is mediated through the continuity or the superficial muscle fibers between the RV and the LV. The two ventricles share the myofibers, the septum, the coronary blood flow, and the pericardial space. And the RV volume load shifts the septum towards the LV. The LV pressure volume loop also shifts to the left with reduction in the LV volumes. So the bottom line, with progressive RV dysfunction, LV function deteriorates. Ventricular dyssynchrony, both intraventricular and interventricular, would contribute to adverse RV-LV interaction. And remember, there are physiological factors which also link the two ventricles. After all, it is the RV output which gets into the lung and comes into the left atrium as the left ventricular preload and the cardiac output. Hence, either obstruction or regurgitation in the right ventricular outflow tract is a threat to the LV preload and hence to the cardiac output. We already discussed how the change in RV size and shape can influence the LV and its output. And what decides the position of the ventricular septum is the pressure gradient in end diastole between the two ventricles. Normally, the pressure in the LV in diastole is higher than RV. So the septum bulges into the RV and septum behaves as if it is a part of LV. This is altered when RV is distended, as the septum will bulge into the LV. Number of pre-op factors can affect LV function in repaired tetralogy fallow. This includes abnormal coronary artery anatomy, the periods of cyanosis that the baby has gone through, left ventricular volume overload from palliative shunts, and today we know that the LV ejection fraction in an adult with repaired tetralogy on cardiac MR is dictated by the RV ejection fraction, the duration of palliation prior to repair, and aortic regurgitation, if any. So that's a lot of introduction to explain what we are going to do. This introduction was to understand the problems that we are going to look for. But how are we going to look for it? Just as you would see any other patient, in a PET repair patient, you need to take a history. Is there any effort intolerance? That effort intolerance can come from RV dysfunction, and when RV dysfunction has happened, remember there is a left ventricular dysfunction also. So both the ventricles could be dysfunctioning. Any history of palpitation? As the repaired patient grows older, both supraventricular and ventricular arrhythmias can come into the picture. A history of syncope could be ominous. It means a fast rhythm in the form of either an atrial flutter or a ventricular tachycardia. It can also be a late occurrence of complete heart block causing a Stokes-Adams attack. Totally unrelated to the heart, remember, here is a child who has undergone a major surgery in early childhood or infancy, and the neurodevelopmental evaluation of such a patient is important. And with our increasing recognition of the neurodevelopmental and psychiatric impact of 22q11 microdeletion, this also will enter into our assessment. When you examine, you are going to look at growth and development. You need to see the blood pressure. You're dealing with an adult. A higher blood pressure in the setting that we discussed worsens the cardiac dysfunction. On the other hand, a lower blood pressure may denote a lower cardiac output. If you look at the JVP, it's commonly raised. Remember, the tetralogy fallow which is repaired quite often has a restrictive physiology. It's a hypertrophied ventricle. The end diastolic pressure is elevated, and that's reflected as an elevated JVP. If there is a TR, and remember, quite often there is TR, there are prominent V waves. You would find cardiomegaly or RV outflow tract pulsations when the RV has dilated. You may find, and you should look for, aortic enlargement. We will discuss the importance of this later on. So that is on clinical examination. In the ECG, look at the rhythm carefully. Is it sinus rhythm? It could well be in complete heart block. It could be atrial flutter. There could be premature ventricular contractions or ventricular tachycardia. In the Holter, you may detect these things. And if you're looking at the axis, a right bundle branch block is common, almost invariable. You must look at the QRS duration carefully. The axis is usually right, but a left axis may occur either because there was an inlet VSD or there is a post-op bifascicular block. There is an RVBB with a left anterior fascicular block. Look at this ECG. Since there is no grid, you may have some difficulty in following this. This is a adult tetralogy repair patient, repair done at the age of 10. This ECG was taken at 36 years. You can see that the axis is normal, but if you come to V1, the QRS is quite broad. And this broad QRS, as I said, in the absence of a grid, you can't appreciate it, but it is 180 milliseconds. In the chest X-ray, you look for the heart size, see whether the RVOT is enlarged, look for any RA enlargement in severe TR, see whether the ascending aorta is enlarged, look for lung vascularity. The vascularity may be different between the two lungs if there is a severe pulmonary arterial stenosis on one side or if there are collaterals. And then you're going to look at the echo. Remember, while looking at the echo, you're looking at residuae, sequelae, and complications of tetralogy repair, and then a functional assessment. Residual VSD, residual RVOT obstruction, pulmonary artery stenosis, assessment of the severity of pulmonary regurgitation. We'll spend some time on this. Tricuspid regurgitation, assessment of RV function. Again, we'll spend some time on this. LV function, the ascending aorta, and collaterals. So when you start doing echo, do it your usual way. You go by your segmental anatomy. You have established the anatomic, that the segments are appropriate. You are looking at the anatomic lesions. Once these have been made out, with color flow and spectral Doppler, you would look at some geometric parameters in both 2D and 3D if you have, and non-geometric parameters as well. Doppler study is your key tool for getting hemodynamic information for decision making. And your assessment of PR severity has to be done by Doppler to begin with color Doppler. And how do you quantify PR severity? We are going to assess that. But as an eyeballing, you can use the color Doppler, the width of the Doppler jet, and the diastolic flow reversal. A diastolic flow reversal beginning in the pulmonary arterial branches is an evidence of severe pulmonary regurgitation. Therefore, by looking simply at the Doppler color flow images, you have got an idea as to how bad is the PR, mild versus severe. Then, when you are looking at spectral Doppler, there are parameters which will help you to assess the severity. These are sort of binomial in the sense that you are assessing as mild versus severe. 4 parameters can be checked. One is pressure half time. Like in any regurgitant jet, it's the time taken to reach half the pressure gradient. Your current day machines will give you direct readout on the pressure half time. As far as RV and PR are concerned, less than 100 milliseconds would denote severe PR. You can look at a pulmonary regurgitation index by relating the duration of the PR flow to the duration of diastole. How much part of diastole contains the PR envelope? A figure less than 0.77 denotes severe PR. You can also relate the PR jet to the pulmonary annulus, just as you would relate an aortic regurgitation jet to the LVOT. And in this case, a value more than 1/3 denotes severe PR. You can be little more geometric. You can look at a diastolic to systolic time velocity integral. And this is looking at the spectral envelopes of both the diastolic flow and the systolic flow. And if the diastolic time velocity integral is more than 0.61, that is evidence of severe PR. Of these 4, pressure half time and the jet annulus ratio best correlates with cardiac MR severity. So this is illustrated in the findings of this particular study. If you look at pressure half time, the values are given here as to what is significant and what is mild. So of the 4 parameters that we have said, the maximum correlation for the severe PR as estimated by cardiac MRI is for these 2 parameters, pressure half time and jet width by annulus ratio. This illustrates how the pressure half time is taken. This is the PR jet and this. And moving to something else, we have an inherent problem in assessing RV function. For instance, we don't have a formula, unlike say the Simpson's rule in the LV, for assessing the left or right ventricular ejection fraction. it is foolish to try to apply the left ventricular volume calculations to the right ventricular volume. Never do that. There are certain surrogate markers which have evolved. One of them is to combine the fractional shortening of the RVOT with a fractional area change of the right ventricle. That is, the RVOT, this is an image that you are familiar with. Here, measure the RVOT right under your beam from the RV anterior wall to the aortic wall. Get a value in end diastole and end systole, and the difference is the fractional shortening of the RVOT. Also get a 4-chamber view and optimize it for the RV so that you can get an area in diastole and systole. So you can get a fractional area change. Your problems in geometry will intervene when you try to extend this value to a volume. So don't extend it. Take it as a fractional area change. The studies have shown that if you combine the RV fractional area change and the RVOT and 25 together would denote significant RV systolic dysfunction. And the correlation is with an RV ejection fraction less than 35% on cardiac MRI. So a combination of these two markers which addresses two different parts of the right ventricular geometry. The apical 4-chamber view captured in the fractional area change and the RVOT captured in the RVOT fractional shortening. A combination of this can predict a RV dysfunction on cardiac MRI. Geometric parameters that you can look at would be on 3D echo also. You can look at the pulmonary valve morphology and see the pulmonary flow. And but even though people are estimating RV volumes and ejection fraction on 3D, the currently available equations for calculating them and the programs for calculating them underestimates the volume and the ejection fraction relative to the MRI derived volumes. Remember, cardiac MR is the gold standard for assessing RV function. We are used to looking at some other parameters in adults like TAPSE, the tricuspid annular plane systolic excursion. Its reliability in children is very controversial. In adults, if the value is less than 18 millimeter, you call it a longitudinal dysfunction of the RV. In children, this is not reliable generally, but some people have tried to correlate it with to the RV longitudinal diameter and derived a fraction as TAPSE divided by RV longitudinal diameter. If it is less than 25%, it could suggest longitudinal dysfunction. This is a measurement of the TAPSE. The other commonly assessed functional imaging in adults, mind you, you are dealing with adults in this population predominantly, and therefore your adult colleagues will be overlapping with your assessment, and they are used to looking for these. So you should know how much is it reliable for your purpose. The major limitation is angle dependency when you are looking at tissue Doppler imaging. But there are some parameters in this, notably the isovolumic acceleration time. What is this? It is the myocardial acceleration during the isovolumic contraction of the tricuspid lateral annulus. And you can calculate the isovolumic acceleration time as a ratio of the peak myocardial velocity divided by the acceleration time. Too much of physiology it might look, but essentially when you are getting the tissue Doppler image from the tricuspid plane, this is the isovolumetric contraction. This is the systolic wave related to the isovolumetric contraction, and the pendency of this curve is what shows the isovolumic acceleration. So from this it is possible to get this value, but it calls for a lot of focused physiological study with excellent equipment, so few people do it. Similarly, you again have commonly used adult parameters for LV function like a strain and strain rate. Your present day equipments would allow you to calculate this. So people have just off-label used the LV equations for this and put it on the RV and reported that longitudinal strain could be impaired in the presence of pulmonary regurgitation and RV dysfunction. This is the sort of curve that your machines would give you. And in presence of a dilated RV, a obstruction to RVOT, or a very restrictive RV, your longitudinal strain is low. And if you can find this from regional wall motion assessment, it may detect early RV dysfunction. At this point, this is only enumerating some of the areas in which work is being held in echocardiographic assessment of RV function. But as we said, the gold standard is cardiac MRI. We discussed echo in some detail because that is what you and me are going to do. And you need to find out when you would send a patient for MRI. After all, we can't afford to send the patient for MRI very often. Significant RV dilatation in echo indicates the need for consideration for percutaneous pulmonary valve implantation. That is why assessing what is significant RV dilatation, how much is the RV function impaired, some of the echocardiographic parameters that we discussed so far are helpful in identifying the patient who should go for MRI. And once the patient is going for MRI, we look for things like pulmonary regurgitation fraction and volume, RV end diastolic and end systolic volume, the ratio between RV and LV volumes, and the RV ejection fraction. We are going to define criteria based on this. This is in a tautology of fallow absent pulmonary valve where patient has developed a recurrent obstruction. This is the occurrence of sorry, I hope you can see this image. This is the sort of image that you will get in cardiac MRI. If you find the RV, the stenotic outflow, the dilated main pulmonary artery, the left atrium and the venous return into the LV. It may not be moving as well as I would like it to, but the purpose is to show both the ventricles and the outflow tract. We must particularly be aware of late issues following TET repair. Remember, these patients may be candidates for interventions like pulmonary artery stenting when there is a significant stenosis of the RPA or LPA. We need to define the indication for pulmonary valve replacement on a very different plane. When you are evaluating their electrophysiologic status, they may require pacemaker implantation. They may be candidates for automatic implantable cardioverter defibrillator. They could get endocarditis. And these are adult women. They would have issues with contraception and pregnancy after repaired TET. We are going to discuss that. And the neurodevelopmental outcome needs to be assessed. So when do you replace pulmonary valve in an asymptomatic patient? I'm relying on the landmark paper by Tal Jiva from Boston Children's Hospital. I would strongly recommend you to go through this paper, who has laid down these criteria based on cardiac MRI, the end diastolic volume indexed to the body surface area of 150 ml or end systolic volume 80, an ejection fraction less than 47, LV ejection fraction less than 55, RVOT aneurysm, long QRS duration more than 140 milliseconds, more than 180 predicts less chance of the RV returning to normal. If you have recurrent ventricular tachycardia, if you have a concomitant lesion requiring surgery, like severe aortic regurgitation, an ascending aorta which is bigger than 50 millimeter, or pulmonary artery stenosis not amenable to surgery, you would have noticed that these are essentially considerations for a patient going to have a surgical pulmonary valve. This is an instance where you find that a patient had severe pulmonary regurgitation and he has had a perimount bioprosthesis, thereby abolishing the pulmonary regurgitation. In symptomatic patients, presence of heart failure, syncope, and effort intolerance which is objectively verifiable are indications for pulmonary valve replacement. And for percutaneous pulmonary valve, remember I mentioned that the earlier indications as Talgiva laid down were largely for surgical pulmonary valve replacement. For percutaneous pulmonary valve, stenotic, regurgitant or mixed lesions after RVOT surgery. In tetralogy of Fallot or a conduit repair is an indication for percutaneous pulmonary valve. Symptomatic patients, the category of patients where this would be required would be symptomatic patients with severe PR and RV dysfunction or dilatation, or symptomatic arrhythmias, patients with severe PR, RV dysfunction by echo, MRI, radionuclide study, and objective evidence of effort intolerance, and patients with moderate or severe PR when there is an additional lesion requiring intervention. And you know that the currently available valves are preferred for the RVOT conduit, but you can stent the native RVOT in repaired tetralogy and do a percutaneous pulmonary valve. This shows the commonly used percutaneous pulmonary valve, which is the Melody valve, and you can see that once the valve is deployed, we are injecting into the main pulmonary artery. There is nothing leaking into the RVOT, so the pulmonary regurgitation has been abolished. And this frame also shows a stent in a PA branch, which is the LPA, and that is because quite often these patients require a pulmonary artery branch stenting or have already undergone it when you are evaluating them for a Melody valve. The disadvantage of the Melody valve is the size limitation. You can't use it if the RVOT is bigger than 22 millimeter. The other valve, the Edwards Sapien valve, you can use up to 29 millimeter or even slightly bigger with the newer valves which are coming in. And what happens to the right ventricle once you have replaced the pulmonary valve? What you would expect is that the RV systolic pressure would come down immediately if it is higher to begin with. You would expect decrease in the right ventricular hypertrophy as well as dilatation. TR would decrease, the RV ejection fraction would increase, and your cardiac index response to exercise would increase, and therefore there would be a better effort tolerance and better VO2 max in cardiopulmonary exercise testing. So these are the expected benefits of pulmonary valve replacement, and you should be able to see these in 3 months if everything has gone well. But life is not necessarily great after pulmonary valve replacement, because for every 100 patient years, 4.4 would require re-intervention. In 75%, it's related to restenosis, 15% to endocarditis, and 2% to pulmonary regurgitation. Therefore, the patient who has undergone a pulmonary valve replacement requires a frequent scheduled screening. And if there is an emergency, of course, needs an urgent evaluation. And the screening would involve a physical examination, ECG, a fluoroscopy, if not fluoroscopy, a chest X-ray in both AP and lateral views, echo, CT or MRI, and exercise testing. This is not to suggest that you need to do all of these in all the occasions. You, of course, would do a physical exam, ECG, and echo probably on every visit. Maybe once in 6 months or once in a year, you will need a fluoroscopy. When there is a problem identified, you will need a CT or MRI. Definitely a year later, it is better to do a CT or MRI. And an exercise testing is part of evaluating the patient. And what are the problems that you would be looking for? Early after pulmonary valve replacement, look for a residual gradient, pulmonary regurgitation, paravalvular leak, an acute valve failure, an early stent fracture, or even early endocarditis. And late, pulmonary valve stenosis, regurgitation, endocarditis, and endocarditis tends to occur as 1.4 per 100 patient years. Arrhythmias after tetralogy repair is a major problem. And the late mortality in tetralogy cohorts increases from 0.24 to 0.94 per year. That is 1% per year the mortality is increasing after the first few decades. And this is predominantly due to VT and VF. And a small number due to late complete heart block. And when the child had a complete heart block after surgery and recovered, especially a delayed recovery of complete heart block predicts a greater chance of a late recurrence of complete heart block. And supraventricular arrhythmias would occur in as many as 30% in late follow-up. This is atrial fibrillation, flutter, or focal atrial tachycardia, or reentrant tachycardia. Anything can occur, atrial flutter being the most bothersome thing. And this is a cause for morbidity, heart failure, stroke. You can also get ventricular tachycardia. Reoperation and mortality are all there in this cohort. And in understanding these arrhythmias, we need to go back to some physiology and remember that arrhythmias and SCD post-pathology repair may be related to an older age at the time of repair, progressive pulmonary regurgitation, systolic and diastolic dysfunction of both the ventricles, a long QRS duration, particularly more than 180 milliseconds, and other arrhythmias, including atrial tachyarrhythmias or heart block, may also be present. And electrical instability results from the anatomic factors related to surgery and mechanical events such as ventricular dilatation and stretching, and abnormal fibrous tissue at different sites in the RV and LV, and fibrofatty substitution that would occur in and around the surgical scar. These all provide the substrate for reentrant arrhythmias. And if you want to risk stratify patients for ventricular arrhythmias and sudden death when you're seeing a late follow-up in pathology repair, age at surgery, ECG features like RBBB, QRS duration, how much of variability there in the QRS duration in the 12 leads, is there any QT dispersion, what is the RV end diastolic volume, the signal average DCD if you are using late diastolic potentials may be used by some in Holter monitoring recurrent VT and VF, and also in Holter monitoring analysis of the microvolt T-wave alternance as a risk for ventricular arrhythmias has been used by some people. So the structural and hemodynamic abnormalities, we already said, the outflow tract aneurysm, the RV volumes, and the higher RV pressure. These are predictors of arrhythmias. And autonomic nervous system has been evaluated recently by the MIBG technique to identify those with structural abnormalities of nerve endings and receptors. If you look at this case scenario, this is a 36-year-old electrician who was repaired for pathology at the age of 10 years, and he had a residual VSD which underwent surgical closure 2 years later. He was all right till he reached the 30s when he started having progressive effort dyspnea and fatigue. He had 2 episodes of syncope with a wide QRS complex tachycardia. His ECG had shown normal sinus rhythm, right bundle branch block, and a QRS duration of 180 milliseconds. His was the ECG that I showed you in the beginning. His chest X-ray showed a cardiomegaly with 65% cardiothoracic ratio. In 2D echo, he had a free pulmonary regurgitation. He had an RV internal diameter more than 42 millimeter with severe RV dysfunction. He did not have a cardiac MRI. This was his ECG. On a superficial look, you would think this is a VT because it's a wide QRS complex tachycardia. But if you can concentrate here, you can find that the essential morphology of the QRS in sinus rhythm is similar to the QRS during the tachycardia. This is actually atrial flutter. So this patient had an EP evaluation and RF ablation for atrial flutter, and he underwent a surgical pulmonary valve replacement with a perimount bioprosthetic valve. This was the image of the pulmonary valve that I showed earlier, and he had a right ventricular reduction done by the surgeon. He had a very stormy post-op period, but he went through that without much problem, and he has been doing well, barring a few episodes of atrial flutter in between. People have now applied CRT for severe cardiac failure in adults with repaired pathology of fallow. Remember, we are following up a difficult cohort over a long period of time, so you're going to see a 50 or 60-year-old patient in severe cardiac failure. And one of the things that has been tried, even though in very small numbers, is to try CRT in them. And there are two reports which I would refer to here. One was with a group of 10 patients. They are like 44 years was the mean age. And this CRT, there was a significant functional improvement. And in another report of patients in 60s, again, CRT caused significant positive response with an additional RV lead, what they designated as CRT-RV. So this is emerging as one of the available modes of therapy in a small subset of repair tetralogy of patients with severe cardiac failure. Contraception and pregnancy is a different issue. We need to educate potential mothers as to why they should plan their pregnancy, and therefore they should know different techniques of contraception. And remember, it's not only a female issue. The male patient with tetralogy of Fallot also has a risk of transmitting the disease to his offspring. So his offspring needs to be screened, and we are going to recommend a fetal echo to the mother. It's not only if mother was the affected parent, but also if the father is the affected parent. And women can choose from the full range of contraceptive options, but those with a large right ventricle, tricuspid regurgitation, and ventricular dysfunction may refrain from the oral contraceptives because of the thromboembolic risk of estrogen. If it's a good repair, pregnancy is well tolerated like normal women, and for an individual patient, the risk of pregnancy would depend on the severity of any residual lesion, degree of ventricular dysfunction, and the likelihood of developing an arrhythmia. Endocarditis is rare after tetralogy repair, but it can occur, and it is particularly infamously more after pulmonary valve replacement, especially with the Melody valve. And you need to be alert to this possibility. Patients need to maintain excellent oral hygiene, and our endocarditis prophylaxis should be carried on, particularly for those with conduits and prosthetic valves. But when there are gross structural abnormalities within the heart, you may liberalize this indication. What happens to the aortic root after tetralogy repair? Remember, in tetralogy and pulmonary atresia, the ascending aorta is dilated. At birth, the absolute diameter of the ascending aorta is increased. Even in the fetus, in the later stages of fetal life, you find the aorta dilating. Why is this happening? We have traditionally believed that this is because there is a greater volume which is going through the aorta because the pulmonary artery is obstructed. But the fact that there are histologic and elastic abnormalities in these patients in the aorta in quite a few may suggest that there may be an underlying genetic problem and the aortic dilatation may be pre-programmed. This can cause AR, and you may need to replace the aortic valve for AR. And as a very, very rare complication, you may get aortic dissection and severe aortic dilatation requiring aortic valve replacement. And following tetralogy repair, there is a tendency for significant regression of aortic sinus measurements. But in some patients, this does not happen, even though data suggests that early repair may prevent aortic dilatation. Neurodevelopmental outcome is an entirely different ballgame. All children, you need to be careful with regard to their neurodevelopmental status. And they tend to have lower scores on intelligence tests, mild impairment of fine motor skills, and difficulties with language tasks in large groups of repair tetralogy children. And adolescents with TET repair also tend to score lower on the physical health and psychosocial testing parameters. And these things may also be associated with a hyperactivity disorder, learning disability, and later in life psychiatric problems, especially if there is a 22q11 deletion. Remember, this occurs in 8 to 15% of tetralogy, and this may be diagnosed for the first time in adulthood when you are seeing the, say, 30 or 40-year-old patient with repaired tetralogy in early childhood. This 22q11 status is likely to be unknown. And so you may be the first person to diagnose it. Dyslexia, behavioral abnormalities, psychiatric disorders all may be associated. And genetic diagnosis would allow early recognition and treatment of the known cardiac problem. And once a parent is diagnosed as 22q11 deletion positive, it can be an autosomal dominant problem with a 50% risk to the offspring. So genetic assessment and counseling would be needed for potential parents, especially in presence of problems like facial dysmorphism, learning disability, and when you don't know the 22q11 status. With all these, let us also look at the brighter things. A child born with tetralogy today can be expected to have corrective surgery by 6 months with a 96% chance of survival to hospital discharge in places where access to surgery is not a problem. And during childhood, there's a 5% risk of reoperation and another 6% risk of catheter intervention. You need pulmonary valve replacement for repaired tetralogy at the rate of a little less than 1% per year. Obviously, those with pulmonary atresia or absent pulmonary valve will need pulmonary valve replacement more often and more likely. If you're looking at a 30-year-old repaired tetralogy, what is his annual risk of death? It's 0.5%, where it is normal is 0.15% for male and 0.06% for females. And this risk increases by 0.1% per decade. And the increasing adverse outcomes with age are related to the pathophysiology of repaired tetralogy. So the unnatural history of tetralogy repair, there was a recent paper on a 40-year follow-up of tetralogy repair in Holland, and the cumulative survival after 40 years was 72%, and the event-free survival was only 25%. And the late mortality was due to heart failure and ventricular fibrillation. And the subjective health status was similar to normal people, but there was a progressive decrease in RV and LV function with time. They did not notice any increase in the aortic root dilatation, and late mortality was correlated to prior shunt, hypothermia during surgery, early post-op arrhythmias, and when there was an increase in QRS duration, ventricular dysfunction, and decrease in exercise tolerance, these things were present, but in this study, this was not related to mortality. And late arrhythmias was, however, related to a transannular patch. Thank you. I know that there's been a lot of data in this, but you should remember that repaired tetralogy is a new disease. We are understanding the physiology of this, and we are understanding how to evaluate this. This is an ongoing process, and you are welcome to ask any questions.